morning and welcome to our Sickle Cell Data Collection Program for California webinar series. I'm Faith Rader from Tracking California's Sickle Cell Data Collection Program, and I will be today's moderator. I want to thank all of you for joining us today. We have a great webinar planned. Dr. Wally Smith is the Florence Neal Cooper Smith Professor of Sickle Cell Disease at Virginia Commonwealth University, which I will now call VCU. He also serves as the Vice Chairman for Research of the Division of General Internal Medicine and is the former Scientific Director of the Center on Health Disparities at VCU. In addition, he's a member of the Institute of Medicine's Committee on Standards for Trustworthy Guidelines. Dr. Smith is an experienced implementation scientist and an expert in clinical and health services research in sickle cell disease. He has authored over 100 publications and served as an investigator on over 50 externally funded grants and contracts. These include the NIH-funded Pain and Sickle Cell Epidemiology Study, or PICES, for which he's the principal investigator, the Cooperative Study of Sickle Cell Disease, the multi-center study of hydroxyurea in sickle cell disease. Oops, I believe those are two separate studies. The Sickle Cell Disease Clinical Research Network, for which he is the VCU site principal investigator, the Sickle Cell Disease Outcomes Research Network, and the NIH-funded VCU Basic and Translational Research Program, BTRP, in sickle cell disease, for which he is the principal investigator. Dr. Smith has been associated with the development of two potential lead compounds for sickle cell disease at VCU. He has been extraordinarily successful at recruitment of sickle cell patients into clinical research, enrolling over 450 patients in 10 years. His latest NIH-funded grant, SHIP-HU, randomizes patients to receive patient navigators to enhance patients' adherence to hydroxyurea. And now I will turn the webinar over to Dr. Smith.
I want to meet that man one day. So what I'm going to do is walk through with you an updated version of a talk I gave a couple of years ago, and it has way more good news in it than it had a couple of years ago. And Mary Houlihan's on the phone from CDC. She and Commander Grant, Althea Grant, have been walking through this desert with many of the sickle cell providers who saw a negative train coming down the track and sought to stand in front of that train. Some of us got run over, but I think we're doing our best to slow it down, is the best way to say it. So I'm going to talk a lot about the law and about policy, and then talk some about science and how those two have met or failed to meet in some cases when it comes to opioid prescribing and sickle cell disease. And I'm going to point out some disparities and realities in that situation. So I'll first tell you about how we got where we are now on the legal and scientific side, giving you some disparities and realities about pain in sickle cell disease and opioid use in sickle cell disease, and about policy for prescribing opioids. And then I'm going to end with some good news, which will be surrounded by calls for action from the sickle cell community. So first, what are some of the disparities and realities about pain and sickle cell disease and about opioid use? So the PICES study that was referred to earlier was a study of patients with sickle cell disease, all comers, adults, and they kept diaries for daily for 6 months. Until then, most people thought of sickle cell disease as an episodic, painful disease that caused pain in emergency room use episodically, but between episodes, the patients were pretty much pain-free. The PICES study turned all of that on its head and discovered this submerged body of water, or submerged pain syndrome, for which most patients never reported to their providers, or providers never recognized it because they never saw the patients during those days. The 3.5% of days when they did see them, the so-called above water part of the iceberg, was when they came for the hospital or came for the emergency department. But there was another 13.1% of days when they said they were in a sickle cell crisis. The patients used that word, crisis, but they did not come for care. So 3 out of 4 days when they were in crisis, they were actually at home. Another 39.3% of days, they were still having sickle cell pain, but it wasn't bad enough to call it a crisis. The mean pain on those days was about 4.2. And then only half of the days overall, less than half as a matter of fact, did patients say they were not in pain. So what we learned is that there were some patients in pain every day, and that's not shown on this slide. Another group of patients in pain for most of their days, and a small group of patients not in pain for most of their days. So it's exactly the opposite of what the public and what practitioners thought. We also learned, as I said before, that when a patient says they're in a crisis, they'd rather stay at home. And this is anecdotally what patients will tell you. I don't want to go to the emergency department. They don't treat me right down there. They don't give me the pain medicine I need. I can do bad all by myself. So 3 out of 4 days, the patients were actually staying at home, even though they said they were in a crisis. And this got everybody to thinking, well, if they're in pain all the time, that's pretty much chronic pain. And we are not treating sickle cell disease the way we should, and we need to rethink our entire treatment paradigm and reorganize our healthcare system to not manage patients as if they're having episodic pain that goes away and they need nothing in between. So sickle cell ended up being one of many types of chronic non-cancer pain. Basically, that's defined as pain that persists past the normal time of healing. Many different definitions, 1 month, 3 months, 6 months. But chronic pain is pain beyond past a time of an acute pain exacerbation. Very common, very significant burden to adults, known to lower quality of life, poorly managed, and associated with any number of short-term and long-term psychological and psychosocial effects, including anxiety, distress, catastrophizing, kinesiophobia, somatization, all kinds of outgrowths of this pain, which you can imagine if any of you on the phone have chronic pain, you can imagine that it affects your life because you don't know what your next day is going to be like. It is hard to plan and certainly hard to work and hard to get through life. So the situation was such that we did not have a diagnosis of chronic sickle cell pain for research and clinical purposes that we could refer to help the world know when a patient was having chronic pain and not just their normal acute crises. So we set about doing that via the American Pain Society and a group called the Analgesic, Anesthetic, and Addiction Clinical Trial Translations, Innovations, Opportunities, and Networks, American Pain Society Pain Taxonomy Initiative. Shorten that, AAPT. We came up with a diagnosis of chronic pain as being ongoing pain present on most days over the past 6 months, either in a single location or in multiple locations, and one sign of pain sensitivity or palpation in the body. We allowed 3 diagnostic modifications, so one could have chronic sickle cell disease pain without contributory disease complications, chronic sickle cell disease pain with contributory disease complications such as avascular necrosis, bone infarction, skin ulcers, any kind of local obvious pain source And then we allowed this, frankly, it was a punt. We allowed mixed pain phenotypes because everybody recognized from the Pisces study that all that pain patients were having couldn't possibly be ischemic pain, that some of it could very well be neuropathic pain. But we didn't have enough proof from laboratory and other imaging kinds of tests to make a diagnosis of neuropathic pain. So we put in this mixed pain phenotype category, allowing for more research to prove the presence of and prevalence of neuropathic pain among patients with sickle cell disease. It makes a lot of sense that patients could have that neuropathic pain. One, they could have it because they damaged neurons from ischemia, just like you damage other parts of your body, other organs from ischemia due to sickle cell disease. Second, there's this idea of central sensitization, which is a brain disorder that basically mimics phantom limb pain. So the brain thinks that there is pain going on, even when there's not a nociceptive stimulus in a location to demonstrate that action potential, initiate an action potential in the central brain. So here's a picture of what I'm talking about. So the squiggles are theoretical vaso-occlusive episodes that have happened from 6 months on all the way through adulthood. They may slow down, they may continue on, they may not be regular, they're unpredictable, they're acute, certainly intermittent, and they have a very well basis in the vaso-occlusion and the vasculopathy associated with sickle cell disease. The neurons that are firing from that kind of pain are nociceptive neurons, and those neurons pass the signal along. So if you take the stimulus away and they stop firing, the signal goes away. You could also have nociceptive pain from bone and tissue necrosis, like avascular necrosis and ankle ulcers and so forth. That's demonstrated by the boxes. You can hardly see those boxes overlaying the squiggles. But that might theoretically raise its head as late as 10 years of age or as late as 20 years of age, depending on the organ deterioration, such as the hip or the skin, that results. And then there's this neuropathic pain, neuroplasticity with central sensitization, or local neuropathic pain from damage of neurons. Don't know as much about that, but theoretically that takes a while to raise its ugly head as well. So we drew here that it would take almost 20 years for that to happen, but most people think it happens somewhere in the between the first and second decade. And then last, opioids may actually be bad for you, may actually induce hyperalgesia. Well, there's some proof of that outside of sickle cell disease, and we allow for that to happen in some small percentage of patients. There are about 100 genes that regulate pain control, opioid sensitivity, and opioid metabolism. We cannot explain opioid-induced hyperalgesia genetically or predict it genetically currently, but people are hoping to try and do so with GWAS and giant computers that do these very, very complex predictive models. Suffice it to say that in some patients, they have hypersensitivity to touch that's actually induced by opioids. So I've discussed nociceptive mechanisms, which would best be treated with preventive agents to stop the sickling itself, peripheral neuropathic damage and sensitization, which presumably could be treated with local care at capsaicin or maybe lidocaine, and then central neuropathic and other disorders, which we really don't know how to treat in sickle cell disease, but there's the guess of gabapentin or Lyrica or even Tegretol and other drugs like that. We're in the forefront of learning about how to treat these syndromes, first diagnosing these syndromes, but second, learning how to treat them. We do have a phenotype for what we call neuropathic pain that suggests after nerve injury, maladaptive changes can occur that leads to spontaneous pain, that's part of the phenotype, or pain hypersensitivity. That's another part of the phenotype. So you touch somebody and they say, ouch, that's pain hypersensitivity or hyperalgesia. The spontaneous pain is called allodynia. That means other kinds of stimuli can cause pain, or they just have pain spontaneously. Very, very complex to try to explain it. There's a central sensitization wind-up theory, but the predictability of this is not very high. And in sickle cell disease, not well documented and explained. How do you treat pain? That is a very tough question. We know, however, that opioids have been used to treat pain for decades, for centuries. So far back that Thomas Sydenham said, of all the remedies it has pleased Almighty God to give man to relieve his suffering, none is so universal and so efficacious as opioids. Should you be giving them every day, or should you be only using them for a short term? I think that the jury is still out on whether you should use opioids every day for long periods of time. It is not out on whether you should use opioids short term for hospitalization. And I don't think I'm going to cover most of that literature today, but suffice it to say the NIH settled the question with a consensus statement based on good evidence, many randomized controlled trials. There is no reason to withhold opioids short term in the emergency room or in the hospital for a patient having an acute exacerbation of their sickle cell disease pain and asking for help. There's no dose limit. There is no reason to dose titrate slowly. You can dose titrate rapidly. But what we don't know about is what to do for this chronic non-cancer pain, including patients with sickle cell disease. I can tell you that in the 80s, 90s, and the 2000s, and I was a part of this, the belief was that we were underutilizing opioids everywhere and that we needed to use them more, and we went around the country preaching to do that. We have now begun to retreat from that advocacy and ask the question, is it safe and effective to use long-term opioids? In sickle cell disease, in low back pain, in pelvic floor syndrome, in TMJ, in irritable bowel syndrome, so forth. And one of the reasons we retreated is because of this idea of opioid-induced hyperalgesia. Basically, this slide is telling you that long-term opioid therapy is associated with, not necessarily causal of, more depression, more central sensitization as measured by quantitative sensory testing, and that nociceptive processing in the patients who are on long-term opioids differs from nociceptive processing in people not on long-term opioids. I'm not going to show you the difficult slide that makes this point, but you can see the article here from Pat Carroll and others demonstrating quantitative sensory testing for these two groups of people. Our research showed that a number of patients, somewhere around 30 or so percent, were on long-acting opioids in the Pisces study. Now, a few of those people used long-acting opioids without short-acting, but most were using combination long-acting and short-acting. A larger number of people were using short-acting alone, 47%, with or without non-opioids. 9.6% of people were using only non-opioid analgesia, and only 4.6% of people used no analgesics in their 6 months of being in the Pisces study. The relationship showed that the pain intensity for the patients on long-acting opioids was higher, and their pain frequency higher than when people were not on long-acting opioids. Is that because the opioids did it, or is that because they were sicker and needed more long-acting opioids? And therein lies the controversy. It was association, not causation. Do people with sickle cell disease misuse their opioids? What is misuse? Misuse is use in any way not directed by a doctor, not according to what's on the bottle, either more or less than what's directed, and supposedly about 3.8 million people who are greater than 11 years of age are misusing opioids based on the National Survey on Drug Use and Health. So that would include people who take a little bit more than what's directed, or more often than what's directed. A large number of people. The reason it's important is because that misuse is a risk factor for ending up on heroin, and heroin is clearly not healthy, clearly illegal, and clearly a disruptive phenomenon in the life of the patient. So it's not a definite gateway. It's a definite gateway, but it's not a definite sure thing that you're going to graduate to heroin use if you misuse your prescription drugs. But you probably want to be made aware of misuse as a physician, both so that you can counsel your patient, not criminalize them, I want to add. That is happening in many states around the country, and I'm going to get to that in a little bit, for misusing their prescription opioids, but certainly counsel them and try and get it under control. More common than prescription opioid misuse is a misunderstanding of three important concepts and the difference between them. I think most docs, when they see a patient who requires high doses of opioids, like many of our sickle cell patients, call them addicted, and that's a mistake. That just means that they have biological tolerance or tachyphylaxis to the opioid because they've been on it for years and years and years, and they no longer respond as quickly or as briskly or as thoroughly to a given dose of opioids. Some patients who are on opioids for long periods of time, sometimes even as short as 30 days, become physically dependent on the opioid. You stop giving it, they have withdrawal. That is not criminal, nor is that misuse. That's physical dependence. If a patient is on a long-acting opioid and a short-acting opioid for any continuous period of time, they're going to have some degree of tolerance and likely some degree of physical dependence. And they are going to have a bad name in the emergency department often, or with the hospitalists when they go to the hospital, because these patients have to have their opioids or else they go into withdrawal. Those patients are not addicted. Addiction is a persistent pattern of misuse or dysfunctional use despite adverse consequences to the patient There's a craving and a loss of control over the use of opioids, dose escalation without reason. And there's preoccupation with obtaining opioids despite the presence of adequate analgesia. We have patients like this. We try and counsel those patients. They're very difficult to treat because they also have sickle cell disease. So yesterday we sat someone down and we explained the first two concepts to the patient. And we said, unfortunately, we think you have the third concept, an opioid use disorder. You're addicted. And we need to help you. And this patient, to give her credit, agreed with us and said, I've already made an appointment at the I think they call it the Crossways Clinic, to get myself some help. So that person had recognized their dysfunctional use and had done something to go about dealing with it. Let's hope all of our patients who have opioid use disorder are that cooperative, but many of them will not be. And they'll say, you're just not treating my pain. The problem is that's the minor portion of the patients with sickle cell disease that I deal with, but the patients are labeled as addicted way, way more often than that. So there's a high rate of tolerance, some level of physical dependence, a low but real rate of addiction. So if you haven't figured it out, this is a tough business, prescribing opioids long-term for patients with chronic non-cancer pain. There's all the reasons to do more prescribing, and there's all the reasons to do less prescribing. And I don't have to tell this audience about the legal dangers from recreational drug use or from doctors being accused of diverting or running pill mills. It requires a high degree of trust between the patient and the doctor. On the other hand, we find patients with sickle cell disease, especially in the rural areas of Virginia, who are suffering unnecessarily because doctors will give them 5, 10, 20 Percocets and say, that's what you're going to get for the month, and don't come back, and then be upset when the patient comes to the emergency room in 2 to 3 weeks in pain, in a crisis. Difficult to measure pain. Pain is its own disease, and even if a person were misusing, it would not disqualify them from getting any opioids the way you would do somebody who had a misuse disorder but no biological disease that requires opioids. So here's some of the reasons to do less, to prescribe less. We know about the opioid epidemic. It's all over the news. It's all over the TV. And it seems a commercial success. The sales went up, deaths went up, and companies are getting blamed for creating the opioid epidemic. Companies are somewhat to blame because as the sales rose, the deaths did rise. I will say we definitely created an appetite in the public for more opioids in the 90s and the 2000s. President Trump has decided that it's an emergency. He said it officially, and so it must be true. It's an emergency. About 10% of chronic pain patients, it is estimated, are addicted. We don't know how to really figure this out because patients are not going to be forthcoming, and we don't have enough psychiatrists to do a diagnostic interview schedule on all of these patients. But somewhere around 10% are addicted. And it could be as high as 20, it could be as low as 3. All right. There's a little evidence that long-term opioid therapy is effective in patients with sickle cell disease, but not much. And for chronic non-cancer pain, the same is true. Some improvement in function and sleep and mood and pain. When you talk to patients by surveys, you get some improvement. There is no other safe and effective alternatives to opioids, except in the case of sickle cell disease, remittive therapies. There are exactly two of those on the market, hydroxyurea and L-glutamine, prescription strength L-glutamine, or Indari. There are no new classes of analgesics being developed, and we have no other evidence that so-called adjunctive therapy, physical therapy, mindfulness, meditation, cognitive behavioral therapy is able to wean people off of opioids. I'd love to see that study. They may get better control of their pain. They may improve functional capacity, but I've not seen studies that they've actually weaned off of opioids. Difficult to diagnose. We have many instruments. The SOAP is probably the most popular instrument right now, but there's many others. The COM, we've used the POMI. Each of these have a false positive rate and a false negative rate. More work needs to be done to get these instruments better calibrated. All right, what about the evidence to actually prescribe? Well, first, despite the opioid epidemic, non-medical use of opioids in patients age 12 and older has not gone up. That might be a shock to you. But that red line tells you that it's really not gone up. What has gone up? What has gone up is heroin and fentanyl. If those of you who don't know what fentanyl and carfentanil are, these are either for human use, drugs that are used for anesthesia. Most of you know how Michael Jackson died. One of the drugs that could have been used instead of the drug that was used in him could have been fentanyl. So it's used to anesthetize the patient, stop them from breathing so you can intubate them, and it also treats pain. They don't care about anything when you give them fentanyl. And so it's killing people because it's making it to the street disguised as Xanax or disguised as some other pill. And people unknowingly often are using fentanyl and killing themselves mistakenly via overdose. Heroin, similarly, being used in larger doses, probably because of prescription opioid sales and the gateway that we talked about. But those are the two things that are actually killing people. As you can see from the blue line, prescription opioids excluding fentanyl, the number of deaths from that, in at least Virginia, is not going up. So just to make the point, here's the fentanyl deaths in Virginia, and you can see 174% increase in a few years. Now, back to sickle cell disease. So the docs and the nurses are worried about prescription drug misuse and about overuse of opioids in sickle cell patients. And this is long precedes the opioid epidemic. So as far back as 1997, Shapiro found that 53% of emergency docs and 23% of hematologists said over a fifth of their patients were addicted. That's the word that they used, to opioids. And 22% of ED docs and 9% of hematologists said over half of the patients are addicted. So if the real addiction rate is 10 to 20%, they're saying it's actually 2 times, almost 3 times as much as the real quoted rate. We recently did a study, and things haven't changed too much. 39 resident physicians were asked to estimate the rate of opioid addiction compared to chronic pancreatitis patients and chronic low back patients, and said that the sickle cell disease rate of opioid addiction was higher. So sickle cell disease gets a bad name, even compared to chronic pancreatitis and chronic low back pain. When we asked the residents, how do you know this? What evidence are you using to make your conclusions and to manage your patients? They said it was their experience, not evidence. But it doesn't matter. Perception is reality. So we have an issue now of patients saying they're under-medicated, doctors saying the patients are over-medicated. And the facts are the patients are not dying from opioid overdose. So here's some good data from Dr. Balas and his colleagues showing, actually I'm ahead of myself. This is the use of opioids, actually opioid use in the MSH. Oxycodone is the drug of choice for most patients with sickle cell disease, prescribers of those patients. And I'll skip this slide. This is just same thing, oxycodone. This is the data I was referring to. Opioid-related mortality, not an issue in patients with sickle cell disease. So if you go back from the year 1999, and I think this is the data actually as part of the database the CDC used to make their recommendations in 2016, this is actually data from that. Total of 95 deaths in the bottom right corner from opioid-related mortality, no more than 10 deaths in any 1 year nationwide reported from opioid-related mortality in sickle cell patients. And you can see in non-sickle cell patients, thousands dying from opioid-related mortality. So a distortion, to say the least. If you look at the percentage of sickle cell disease patients on the bottom row who were dying from opioid-related mortality, it's actually 0.77% in that period of time. Compare that to the percent that died from migraine opioid-related mortality, 4.5%. That's 4 times as high. Compare that to fibromyalgia, also 4 times as high. And even low back pain, twice as high. So to point the finger at sickle cell disease patients as being part of the opioid-related mortality issue or part of the opioid epidemic is probably incorrect. So this backlash, as I said, has been recognized by many caregivers. Sophie Lanscron, who's at Hopkins, recognized it. The CBOs are on to this. This is one of our CBOs in the state of Virginia. Quote, one lady who called the office told me she took her last pain pill the previous Friday. Her doctor's reviewing her case, has not written her new prescription. Unable to get her pain meds, I'm sure she'll end up in the hospital because she went to the emergency room to have her pain treated. So we're seeing this. Many of you are probably seeing it in California as well, anecdotally. And then my buddy George Carter here in Richmond, who has the disease himself and is an advocate and in charge of our statewide community-based organizations, was interviewed and said that 3 times in his life his pain was so great he prayed to God to let him die because he didn't think he could stand it anymore. And he was decrying the government response to the opioid crisis, tossing sickle cell patients, in his opinion, under the bus along with everybody else who's suffering chronic pain. So as I said, pain is its own disease. It's associated with many psychosocial and other comorbidities, and they are related to one another. If you hurt a lot, you don't sleep. If you sleep poorly, you hurt more. If you're in stress, you hurt more. If you hurt more, you might have more stress. These things are related. And so we have to think of pain as its own disease. And this is the problem that the national pain plan, which I helped to devise as part of the Institute of Medicine, was trying to address. We think of pain as its own disease. We come out better with a multidisciplinary treatment program that addresses all aspects of pain. That might include opioids, but it certainly includes more than that. Can one reduce opioid use with non-opioids? Well, in this case, a remittive therapy, an acute remittive therapy, now called rivipansel, still in clinical trials. But here's the phase 2. GMI 1070 was the name of it at the time. Here's the phase 2 data saying that acutely you can reduce the use of opioids if you treat the source of the pain, that nociceptive pain that I talked about that causes vaso-occlusive crises. So you can see a dramatic reduction from 57 on the right-hand side, 58 almost, to 13 or so morphine equivalent units in milligrams per kilogram. If you cure sickle cell disease, can you get people off of opioids? Yes, it takes a while. So this is illustrative, suggesting that both the physical dependence on opioids, the tolerance to opioids, maybe even the neuropathic pain that we talked about has to be reversed in order to get people off of opioids. But this is data from Dr. Tisdale at the NIH suggesting you can see reductions in opioid use if patients are cured of their sickle cell disease. Are sickle cell patients on opioids ED utilizers and ED hoppers? Well, we didn't ask that question. We asked, among the higher ED utilizers, were those patients using opioids more frequently than other patients? And we found, no, that's not the case. If you control for the severity and the frequency of their pain, they were using the ED at the same rate. So it leaves us with a dilemma. Let's just suppose that opioids are bad for you. What are we going to replace them with? How would we wean people off of them? Who would pay for the national pain plan to be implemented, where you do multidisciplinary treatment, provide for the behavioral and psychosocial needs, do the cognitive behavioral therapy, do the mindfulness meditation, do the physical therapy, have the groups? Who would pay for those things? And so far, I think the answer is nobody, at least in my hospital. And when it comes to sickle cell disease, it's really nobody. Nonetheless, we have an opioid prescribing policy that most of you know has become more and more restrictive. CDC is at the top, but really it started, I think, with the DEA, and then state boards of medicine, and then maybe the Food and Drug Administration and the CDC following along. And Mary's on the phone. She knows that I know which branch of the CDC is responsible. It was not the sickle cell disease branch, so Mary's off the hook. There were prescribing guidelines that were well-meaning, that were put together by pain societies. They really were part of this pain as a fifth vital sign movement that I talked about in the 1990s and the 2000s, where we were trying to get more opioids in the bodies of patients with sickle cell disease. There was an NIH consensus panel in the 2014 era. Also in 2014, a Pathway to Prevention workshop that was a kind of a jury trial format where some recommendations for chronic non-cancer pain were made, opioid prescribing for that. I already talked about my own work along with the others on the Interagency Pain Research Coordinating Committee for the Institute of Medicine. And then everybody sort of knows about the CDC prescribing guidelines in 2016. So I'm going to briefly go through those. The NIH consensus panel in 2014 was the one that I referred to earlier that said there's no question what to do for acute treatment of a crisis. High quality evidence for giving opioids within 30 to 60 minutes of arrival in the emergency department, the use of opioids around the clock while the patient's in the hospital, high quality evidence. The Pathways to Prevention workshop, on the other hand, did not say there was high quality evidence for what to do for long-term opioid therapy. There's a plus and a minus. There is a dose-dependent risk for serious harms with long-term opioid therapy. There could not be a meta-analysis done for this. Publication bias could not be assessed, but it appeared to be there. There were no placebo-controlled trials that met inclusion criteria, so the evidence is weak. The observational studies that were done were limited in their ability to address potential confounding. But nonetheless, this panel came out on the side that said there is a dose-dependent risk for serious harms for long-term opioid therapy. We did not address long-term opioid therapy in our guidelines and recommendations in 2015. We did say that there was missing studies and that more work should be done, both to characterize the phenotypes that I've discussed with you today, coming up with case definitions for those phenotypes, and to study what to do to treat various kinds of pain. And we suggested new kinds of analgesics and devices and therapeutic delivery systems. And then the CDC, and I'll spend some time on this. These were voluntary guidelines. They were meant for internists, family practitioners, and mid-level providers, people in primary care. Cancer was excluded. Palliative care and end-of-life care was excluded. You had to be an adult. Chronic pain was defined as 3 months. And it offered clarity on other recommendations. They did attempt to be evidence-based using the grade grading criteria for determining the strength of evidence. Here's a summary of what the CDC said. Try not to use opioids. If you use them, don't use much. And please be cautious. Monitor your patients when you do use them. The FDA came along with it and put warning labels and said, don't use opioids and benzos in combination, and we're going to warn you when you use opioids to not use benzos and vice versa. The guidelines came up the right way. Subject matter experts, conflict of interest was avoided. People offered guidance on draft recommendations. The public got a chance to say what they wanted to see changed. And then the recommendations were made final. But we think, as a sickle cell community, that there are problems. First, I've already explained what tolerance is. Patients who are highly tolerant will not fit in the morphine milliequivalent part of the guideline. It's about 100 was the recommended top level. Why? Because if you use more than that, the risks of opioid-related mortality go up. So the dose at the bottom there, greater than 90 morphine milliequivalents per day, is sort of the dose that's out there that is the ceiling dose. Now, the recommendation category was A, according to the grade criteria. That means we really strongly believe we should do this. But the evidence level was a type 3 evidence. So there weren't randomized controlled trials underlying this. It was that survey data that they did showing the dose-dependent relationship between opioid risk and mortality and opioid dose. So our problem is that for sickle cell disease tolerance patients at the bottom of the slide here, those hazard ratios that were calculated probably don't apply. And I think we have indirect evidence of that from the opioid-related mortality statistics I already showed you over a 13-year period. Many of our patients are above 100 morphine milliequivalents per day, milligram equivalents per day. And this says that their risk hazard ratio should be around 9. That is not our experience. Worse than that, people reading these guidelines have taken these suggestions as absolutes and have weaved them into law or into insurance policies, etc. And I don't mean an insurance policy that you take out on yourself. I mean ways of practicing when you decide coverage decisions for opioid prescriptions. Most of you, like me, have heard of something called a prior authorization. Well, we have prior authorization fever in our clinic because most patients have to have some approval for the doses of opioids that they're getting from us. Doctors are viewed as aberrant. I had a pharmacy tell me, I will not fill this prescription that you wrote. I think it is wrong, and I think you are wrong for doing it. Doctors are stopping prescribing opioids now. It's so much trouble getting the prior authorizations. They don't want to be branded a criminal. And so we're seeing the actual opioid prescribing rate, if you look at the statistics, is going down now. So at this point, we have thrown the baby out with the bathwater, in my opinion. We may be causing people not to die because we're not giving them opioids, but what we're not doing is determining which people not to give opioids to. So people have taken these as absolutes. In my mind, some physicians have had mental models already that if you give above a certain dose, it's criminal or wrong or harmful, and I will not do that. I will not give that dose. And this is basically reinforcing that mental model. So the Federation of State Medical Boards are putting laws together, making rules that in 2013 at the bottom here suggest the need for more thoughtful opioid prescribing, and now laws actually coming out saying you must watch your morphine milligram equivalents. Of course, you must check the PMP. You must initiate an opioid trial. You must do informed consent and warn patients of possible death and the penalties for misuse. You have to do periodic drug testing. You have to send patients for treatment, and you have to stop opioids when you feel the trial has failed or when you think they're dangerous. And you better document all this in your medical records. We're doing every one of these things. We're not trying to be afoul of the law. But I'm telling you, it has created a wall of barrier to getting patients adequate treatment. And so in Virginia, we have a prescription drug monitoring program. It's getting easier and easier to use because it's now getting integrated into our Cerner electronic medical record. We're mandated to check that PMP. We're mandated to observe the opioid limits unless we justify it. And I'll give you some good news in a little bit about sickle cell disease. But they want to know very, very strict monitoring of the pill counts and days prescripts. And the insurance companies, the pharmacies, are all in line doing, nobody wants to get arrested. So everybody's in line doing what the rules and the law or even the CDC guidelines say. Even Medicaid is considering not covering certain numbers of pills. We had that come up today. We're going to call Medicaid now one of the companies had said, we will not pay for any more than this amount of pills. It's no longer getting a prior authorization. They're just saying, we will not pay for any more than this amount. So what are the action steps that we need to take as a sickle cell community? During the period of public comment on the CDC guideline, and Mary knows this, we made recommendations that sickle cell disease be accepted from the rules. It sort of is, if you look in the CDC guidelines, it sort of is in there in the fine print that when patients have sickle cell disease, maybe some of these rules don't apply. But I can tell you it's not being observed. That language is not well known nor being observed. We have to follow the rules. Nobody should get in trouble and go to jail. And I know that docs are doing that. I don't have to tell the docs on the phone that you have to follow the rules. But I also recommend that you weigh harms and benefits, making shared decisions with your patients about whether or not to use long-term opioids for their sickle cell disease. And there may be times when you don't, and there may be times when you think you should, and you're afraid to, and I'm asking you to take courage and do it and document well. When I document well, even when I am challenged, I'm usually vindicated. And I have been challenged. I will tell you, I've been visited because of my habit of prescribing these high morphine milligram equivalents for patients with chronic sickle cell pain. But as far as I can tell, the state has backed off. I know that I'm being watched, but I think we are doing the right thing for our patients. Finding providers who are willing to do that, as you could imagine, is difficult. Not an easy job. You're worried about losing your license. You're also worried about patients misusing the opioids, and some are misusing them. I'm admitting some of our patients are misusing opioids. I'm looking to document it and to fight that and to treat them when they do. And in some cases, we have fired patients because it's no longer safe to prescribe for them. But that is not the normal thing that I'm doing. So think about why you should be doing this. The reason you should be doing this is because of what we talked about at the beginning in the Pisces study and the mental model for pain that it results if you take the Pisces study into account. So sickle cell disease pain begins as acute nociceptive pain, but evolves into acute on chronic multi-local vaso-occlusive nociceptive pain with ischemia and inflammatory, maybe transforming to that central pain or peripheral neuropathic pain phenotype. We don't know when, we don't know how often. And we don't know the mechanisms of phenotype transformation. And so we don't know how to prevent it, and we don't know exactly how to treat it. It also means we have to think about how to prevent it. That means more remittive therapy, doing more transplants, getting more people on hydroxyurea and Endari, and any other remittive therapies that come down the pike, doing more clinical trials to get people on these therapies. It means adjuncts, the ones that I've already mentioned. It means biobehavioral therapy that I've already mentioned. All of this needs to be done. So I told you that I had some good news. So George Carter did not put up with what the state dealt him. He went to bat with the State Board of Medicine and actually pushed through, with lots of wrangling and lobbying, legislation to change the Virginia law to allow sickle cell disease physicians to provide higher levels of opioids without forced justification. The law is supposed to become effective on August 8th. So sickle cell disease would join cancer and other terminal conditions in the state of Virginia as being treated similar to a hospice or palliative care situation. And we would hope that at least legally, we would be relieved of the burden and fear of ill effects on our careers because we're doing right by our patients. I'm not expecting that the pharmacies and the insurance companies will change what they do, but I'm hoping at least the law will be more on my side. So with that, I'll stop and take some questions.
Thank you so much. I was just about to tell you you had 5 more minutes, so we're doing great on time. Let's see what has come in for questions. One question is, how is opioid prescription concern different for primary care physicians compared to specialist physicians?
Primary care physicians in general do not prescribe opioids. I think that's a true statement. Some specialist physicians are accustomed to prescribing opioids, needless to say, cancer, but even other specialties, some of them are accustomed to prescribing opioids. So the difference is that primary care physicians in general have avoided opioids, and many of the patients that they treat don't require large doses of opioids. The exceptions to that rule are patients with low back pain, maybe patients with chronic pancreatitis, and patients with irritable bowel syndrome, etc. And for that, the general pattern is refer, not just prescribe opioids, but try to get help. So they get referred to orthopedics, they get referred to rheumatologists, to physical therapy, to cognitive behavioral therapy, etc. And the opioid prescribing is viewed as a gap measure with the goal of getting them off of opioids because they really don't need them. Sickle cell disease is different, though. We believe the patients are going to need opioids lifelong, maybe periodically, maybe long term. So the problem we have is, even if we refer, even if we do all the same things that primary care docs do to try to limit the dose of opioids, there's going to be still a need for opioids. I won't say long-term opioids. I don't know if that's safe or not. I'm giving them, and I'm monitoring closely, and I'm trying to select patients, but I don't know if I'm doing the right thing by giving long-term opioids to patients with sickle cell disease forever and a day. And I want to see more data to help me make those decisions.
Thanks very much. We have this line until 11:30, and the questions are flooding in. So the next one is, what about the use of marijuana in sickle cell patients?
Well, as a Californian, you should be way ahead of me on that. The only trial that I know of that is testing any cannabinoids in sickle cell disease is a trial in California. I don't know the results of that trial. I don't know how things are coming. The problem in Virginia is, while we have sort of medical cannabinoids, we don't have medical marijuana. There are no shops that people can go to. In states like Colorado and other states that have medical marijuana, there is no legal obstacle to patients on their own going and securing these chemicals. Patients tell me that it works and ask me for permission to smoke, and I say, I can't give you that permission. I'm in Virginia.
The next question is, what can or should pediatric hematology do differently to affect some of these issues upstream?
Wonderful question. I'm going to give you maybe 3 things that I think would help. First and foremost, Prepare patients for the transition. Patients who are going to pediatricians have a wonderful feather-lined nest of care with multi-specialty and multidisciplinary therapeutic armamentarium to deal with almost every need, psychosocial, emotional, etc. The insurance infrastructure pays for that quite well. That is not the case for adult care. And in sickle cell disease, the contrast couldn't be sharper. You lose your Medicaid, and it's like the whole world comes to an end. You have no doctor, you have no payment, and maybe even no opioids, and certainly no cognitive behavioral therapy, no psychiatrist, no psychologist, and none of the things that you might have had as a pediatric patient. Prepare the patient for that reality. If you don't have a transition program, develop one, or at least hand the patient off slowly over a period of a year or two, and not immediately and rapidly, so that they have a chance to adjust. And I hope you have an adult practitioner to hand them off to, because that's a problem, the shortage of adult physicians. Second, some patients did begin to use opioids more in their teenage years. And they are the patients that I referred to when I showed those fake graphs of pain increasing around the 20th year. Some patients will start using opioids more. They are feared by the pediatrician because the pediatrician is not accustomed to dosing out more. And the patients are often questioned, what's wrong with you? You never hurt this much before. And my answer is it might be biological, not just psychosocial. So at least look into that and determine if there's a psychosocial impact or factor causing them to use more opioids, or if indeed their disease biology is just getting worse. And my theory is that both may be true in some patients. So walk with them through the part of their life where things start to get worse. Puberty hits, the hemoglobin rises a little bit, more vaso-occlusion. They have more freedom in their lifestyle. They don't drink as much water. They get a little sicker. They go to the hospital a little bit more. They start drinking alcohol. You know the whole story. So that walk with them through that. Third thing, don't demonize the adult docs. We're doing the best we can. Now, a lot of pediatricians think that we're terrible practitioners because we don't do things exactly the way that they do. But the problem is that we have a system of care that is woefully inadequate. And the truth is opioids become a crutch when we don't have a psychologist, or we don't have another way of trying to deal with what is clearly pain that the patient senses is interrupting their life. So we cannot provide the same system of care that I and the National Pain Program, Plan say that we should be providing adults. We're working on that, but it's just not there.
Thanks for that. There is a request for you to go back to that slide you skipped.
Alrighty.
About, is it fMRI and quantitative sensory testing? And,
sure.
And to cover that, please.
All right. Is that the end, or is that the one where I half went through it? I can't remember. Is it the one at the end that they're talking about?
I think so.
I think I skipped over this one, right? This may be the one.
I think this is it.
Okay. So this is a slide that talks about trying to diagnose neuropathic pain or central sensitization using quantitative sensory testing and using functional MRI. Those are the two tools that are out there. And the leaders on this are, I think, on the East Coast as far as sickle cell disease goes, Deepika Dabari at Children's National Medical Center, and many people at Hopkins, including Pat Carroll and Sophie Lanscon's group. Quantitative sensory testing, the key thing to look for is temporal summation. That's how you make the diagnosis. And I'm not a QST guy, so I cannot tell you exactly what temporal summation is or how to interpret QST. For functional MRI, there is a pro-nociceptive connectivity found at the resting functional MRI image. That is associated with a high pain phenotype. People who have anti-nociceptive connectivity on the functional MRI are lower pain and maybe, in Dr. Dabari's experience, maybe people who do better. And I already covered some of the treatment issues: serotonin and norepinephrine reuptake inhibitors, or SSNRIs, gabapentinoids, tricyclics, and maybe trifluoperazine. These are all in anecdotal use, maybe trials underway in some centers to see if these work.
Thanks. There were two related questions. One was, what do you think is the role of the CBO as it relates to the opioid issue? And the other one was more specifically, how can advocates support doctors who are treating sickle cell disease patients and are under scrutiny for the amount of opioid prescribed?
It is a state-by-state battle. I hope that Virginia is a positive example. I hope that this legislation that was passed in Virginia gets picked up by other states, by the Surgeon General, by people who make policy, to recognize, number one, their opioid epidemic is not really a sickle cell disease opioid epidemic. That's the evidence, and these slides show it. Number two, physicians prescribing these opioids are under tremendous pressures. Insurance company pressure, local pharmacy pressure, hospital medical council pressure. They need to be affirmed for what they're doing by community-based organizations who can make the noise and say, you're not treating that doctor right, or that doctor is being pressured and we don't like it. Go to your TV station, go to your newspaper, get it out there that the patients are not being treated right, and here's why. And praise the doctor for doing the right thing. Make some noise. Third, organize as patients and try and help patients understand some of the concepts that I talked about today. A misusing patient is bad for the community. Just one misusing patient can wreck a hospital's opinion of all sickle cell patients. So bring patients in line when they're misbehaving. If they're running around trying to borrow pills from one another, that's bad. If they make bad comments about the doc who's trying to advocate for them, that's bad. If they quit going to therapy, quit going to clinics, that's bad. Try to put positive peer pressure on patients so that they see the need for adherence in order to make their lives and the lives of their colleagues better.
Great. Another question is, has there been any movement in the National Emergency Room Associations to follow the guidelines for acute sickle cell disease pain? I hear from many patients about the under and lack of transfusion and EDs.
Great progress. Great progress. I'm a member of something called the Council for Change. It happens to be a Pfizer-sponsored initiative. But about a month ago, the Council for Change published its first monograph. Front and center in that monograph is an advocacy request to disseminate the fact that it's evidence-based to treat sickle cell pain appropriately in the emergency department. We quote the 2014 consensus guidelines, and we also have a campaign to organize ourselves to disseminate this information, maybe even make it a quality indicator for NCQA. I feel like the Council for Change has the right idea. There are patients involved, there are doctors involved, there are CBO people involved in the Council for Change. If you don't know about it, just Google Council for Change and you'll get a report. You can download it and you'll see that there are ED physicians, hospitalist physicians, sickle cell adult providers, sickle cell pediatric providers, patients, and CBO people. Furthermore, the specialty societies, including the American Society for Hematology, are advocating more for doing right by patients when they come to the hospital. And so there's another movement there to disseminate the guidelines, to have educational seminars, not just for the hematologists, but even for hospitalists and for others likely to care for the patients, so that the patients get the care that they need in the ED and in the hospital. Great progress moving ahead on that. There's a report card that the American Society for Hematology publishes. We're about to publish a second one suggesting whether sickle cell care in the United States has actually improved. You can Google that as well. Just put in American Society for Hematology sickle cell, and you should see a page come up where you can see the report card that was published a couple of years ago and see the many projects that the American Society for Hematology has taken on. Last but not least, the Sickle Cell Disease Association of America is retooling itself to try to get behind this issue of appropriate emergency department care and appropriate hospital care, and to advocate for that. So I think you should see more activity coming from SCDAA around that issue.
We like progress. This may be the last question. Why can't we go to the feds, defined as the Centers for Disease Control and Prevention, the Food and Drug Administration, or the Drug Enforcement Agency, to get the SCD exemption instead of doing this state by state?
I love it. One person going is probably not going to be enough. I've been told the Surgeon General is the right path. I would love it if California joined Virginia and we jointly get a sign-off that goes to the Surgeon General to follow the lead here. I would love that.
Okay, I overlooked one question. What is your recommendation to managed care organization pharmacies about prescribing limits?
That's a difficult one because managed care organizations are of different types. Medicaid managed care organizations are the ones that I have the most familiarity with. And in Virginia, I sit on the quality committee for the Medicaid managed care organization that takes care of a number of my patients. So I wrote the guidelines for that Medicaid managed care organization's policy for managing sickle cell disease. I don't have that much influence on the guidelines for care for every Medicaid managed organization or even non-Medicaid managed care organizations. But it ends up being about treatment guidelines. They have to have them, especially if they're NCQA certified. And you need to look in to see what the guidelines say. And if people ask, I'd be willing to send them. I actually Googled it by mistake the other day. Send them Virginia Premier's, it's Virginia Premier Health Plan, their sickle cell disease treatment guidelines.
Sounds great. People can email me if they want that, and I can send a list on to you.
Okay.
Yes, somebody is saying, can you share your guidelines? Yes. And will the slides be available to us afterwards? Yes. Mary has said, if anyone would like to send me an email requesting a meeting with the Surgeon General, I would be happy to see what can be done. So that's great. And I think that is it. There's a couple questions that I don't know that can be answered, but do you have any closing remarks? This has been really wonderful.
Well, I just want to leave people with, I feel like we were a dark period 5 years ago with regard to sickle cell disease. What do I mean by that? Actually, 5 years ago, there were very few drugs in the pipeline for remittive therapy. That's not true anymore. It could be as many as 15 drugs in the pipeline now to actually ward off the sickling phenomenon itself and to stop organ failure and to stop progression of the disease. That's a new day. We also were feeling like nobody was listening with regard to what to do in the emergency department. That's not true anymore. It's a new day. We have the sickle cell disease guidelines from 2014, and we have 3 or more major advocacy projects to try to get those guidelines disseminated and followed. We also have community-based organizations recognizing their power, learning from the rare disease advocacy groups that are around the country, cystic fibrosis, spina bifida, and some of the other rare disease advocacy groups. Sickle cell organizations are deriving strength from learning the methods of those organizations and their operation. So I recommend, if you're going to do lobbying and do advocacy, make your voice count as a state. Make your voice count as a large group. It's strength in numbers. And I recommend that the community-based organizations put aside their differences. If you had differences before, put them aside and work together on a few things that you can agree about. I think everybody can agree that there's still disparities in the use of opioids in patients with sickle cell disease, and those need to go away. So can we agree on that and sign a letter together or make an advocacy visit together? Perfect.
So there a couple more comments came in saying, can everybody get those guidelines you mentioned?
Yes. You might be able to get them just simply by Googling them, but if you would rather us give them to you as a PDF attachment, we could do that.
Okay, well, I can send it out on the follow-up where I will include a link to the slides and the recording. But right now our time is up for the session. So thank you so much, Dr. Smith, and everybody, thank you for hanging with us. Watch for announcements of our next webinar. And don't forget to like us on Facebook and visit our webpage, casicklecell.org. So thank you so much for participating, and we'll catch you next time.